Hi everyone. I'll be discussing about the management of a preterm baby in postnatal and transitional care. Now, in this, I'm going to focus mainly on late preterm babies, those who look reasonably well and doesn't actually require an NICU admission. These babies are very vulnerable because the problem is they don't look sick and they have a reasonable weight, not requiring any neonatal intensive care admission. So, all these vulnerable babies are late preterm babies, IUGR babies, and in general, we have other high risk babies include LGA babies, babies of diabetic mothers, and babies who require resuscitation at birth but are stable enough to be observed in the postnatal ward. So, what are the risks which are associated with these babies? Definitely hypoglycemia, hypothermia, respiratory distress, and or apnea because they are still preterm, sepsis, hyperbilirubinemia, feeding difficulties and subsequent electrolyte imbalances, in particular hypernatremia, poor weight gain, psychosocial issues. So, one of the most important factors or problems that we face in late preterm babies in postnatal ward is the hypoglycemia. That is because they are having a higher metabolic rate with a limited brown fat stores and low glycogen stores. They are still not grown into the term gestation, temperature instability, and they will always have ineffective feeding due to either a weak suck or fatigue. Next will be hypothermia because of the thermogenesis will be affected due to decrease in the brown fat, and again the insulation is affected because of the white fat, reduced white fat. So both brown fat as well as the white fat is reduced, and there is increased heat loss because of the higher surface area to body mass. The other important thing is the respiratory distress with or without apnea. That is because of the immature lung development. As we have discussed earlier in our slides, if they are, say, suppose if the baby is 34 plus 3 weeker or 34 plus 4 weeker, we don't give any antenatal steroids, or gynecologists may not give any antenatal steroids. However, it was 33 plus 6 weeker, then we'll give it. So, there is, even though it's a matter of 3 or 4 days, there could be a difference. Apart from that, if it is a wrong date, suppose mama's having irregular periods, that could itself be a long date. So they'll have an immature lung development, decreased surfactant. Again, they are still preterm. They may not have the proper breathing control. Lung fluid may not be cleared properly. They have decreased airway tone. So all this can lead on to respiratory distress. These babies, they are still preterm, so that last surge of immunoglobulins from the mother through to the baby across placenta might not have happened, and adequate immunoglobulin might not have been got by the baby, and they are still vulnerable sepsis because of that immature immune system of the baby. The precipitating factors for the preterm birth itself may be premature rupture of membrane, chorioamnionitis, maternal UTI, all those things itself can lead on to sepsis. Exposure to nosocomial pathogens, and in particular in our area, there are a lot of visitors. And so that is another thing, and the visitors usually kiss the babies. So that is one thing that you need to consider. And these babies may need invasive procedure, and any invasive procedure increases the risk factor for sepsis. Now, because they are immature, even though we try and establish breastfeeding, they are still there will be a delay, and there might also be a maternal reason that might have led on to premature delivery. Say for example, if it is maternal preeclampsia or eclampsia, mom may not be um, healthy enough to initiate that breastfeeding. So all this can lead on to sepsis. Another common problem is the hyperbilirubinemia. As we all know, preterm babies have a slower passage of meconium, so there will be a decreased gut motility. There is a decreased glucuronide transferase for conjugation. Again, ineffective feeding and increased risk of dehydration, which will lead on to a vicious cycle and lead on to jaundice. Compared to the term babies, these preterm babies usually peak serum bilirubin at around 5 to 7 days, and we may actually miss these babies if we discharge the baby on day 3, day 4, or day 5. So it is important that they go to nearby pediatrician or nearby hospital and recheck their serum bilirubin levels. And that is an advice not for this baby, for any baby. Now these babies have higher incidence of kernicterus, up to 10-fold increase in risk of hospitalization for phototherapy. Another common thing that we encounter for preterm babies is the feeding difficulty. Because of their immature suck, swallowing, and breathing coordination, they have lower oromotor tone, central nervous system immaturity, limited brown fat stores. These are all compounding to the difficult feeding issues. Difficulty in initiating as well as continuing on the feeding issues. Now, these babies may be separated from mother for observations or for NICU admissions for a day or two, and that might itself be affecting milk supply and establishment. Dehydration, weight loss, and electrolyte imbalances, especially hypernatremia, are consequences to decreased feed establishment and feeding. Now, what are the things that we need to observe, especially in a late preterm baby admitted in postnatal ward? And this is a difficult scenario just because postnatal ward, in my experience at least, the nurses are always concerned about mother and not the baby. So they don't really understand. They are not pediatric or neonatal trained nurses. So we have to tell them what exactly they should be taking care of, and also educate them about the importance. Vital signs, definitely blood glucose levels. We have to weigh the baby. Temperature control need to be educated, and we need to help in feeding the late preterm infant. So, going on to vital signs, monitor temperature, heart rate, respiratory rate, and effort, and ensure that the postnatal nursing staff is well aware rather than just scribbling it down. We have to assess the level of activity, cry, suck, and color of the baby, and if necessary, we need to assess saturations. Say if there has been a meconium staining and the baby is late preterm, then definitely we have to assess saturations at least 4th hourly. We have to ask for the regular bowel and bladder movements, and preferably ask the parents to say how many wet nappies. So nappy count is very important. That gives you an idea of how many the urine output and how well the feeding has been established. Now, as I said, blood glucose monitoring is one of the most important things. So, all at-risk babies in our topic, that is anything about late preterm UGR babies should be screened at 2 hours of age or earlier if clinical signs of hypoglycemia. First feed should be established as early as possible within the first hour itself. The child cohort has actually shown that a neonatal glucose concentration of less than 2.6 millimole, which is approximately 45 milligram per deciliter, has increased risk of impaired executive function and visual motor difficulty by the age of around 4 to 5 years. So if we don't monitor, we won't identify all these risk factors. This may end up having current issues including hypoglycemic seizure as well as future scholastic performances. So it is very important that you monitor the blood glucose level for at-risk babies. How frequently and how long? This is a controversial subject. So I would recommend that you go as per your guidelines, but ensure that adequate number of blood glucoses are being monitored over a period of time, and ensure that those are well above the treatment threshold. So because once the baby gets discharged, this may happen for the next few days. Once the baby gets discharged, we may not be able to check the blood sugar, and the baby can end up to a nearby pediatrician symptomatically with either jitteriness or seizures itself. And once a seizure has happened in secondary to neuroglycopenia, it is irreversible. So my personal preference is to do it at 2 hours of age, and then 4th hourly pre-feed blood sugars until we get at least 3 normal values for a period of at least 24 hours. So once you talk to the patient that this is important, most of the parents are willing, and in my experience I've never had any parent refusing blood glucose monitoring, even though they will have some problems telling that you are pricking the baby. If you tell them that you are pricking the baby for a reason, then they are all happy. So that is one thing that we need to be, this is a preventable cause, so that is why we have to ensure that we adequately monitor the blood glucose. Now what is the threshold of treatment? Again, different guidelines have shown different thresholds. In general, WHO has recommended 2.6 millimole, approximately 45 milligram per deciliter, whereas AP and AAP and NICE guidelines have recommended around 35 milligram per deciliter, even in asymptomatic babies. Now, oral dextrose gel, which is available in the Western world, has been used for management of asymptomatic hypoglycemia in the postnatal ward, which is not available in India. So you can either use admit in NICU and give IV fluids, or you can use formula top-ups. The only problem with the formula top-ups is that will reduce the ketone utilization. So just to beware of reduction in alternate usage compared to breast milk alone. An important thing which we all forget is weighing of a baby with a digital scale. All the babies should have their birth weight recorded. And late preterm babies, we need to at least weigh second every other day, so that we need to ensure that the baby is not losing weight at more than required rate or allowed rate. And if there is a weight loss of greater than 10%, we need to review what exactly is happening, and we need to initiate an appropriate feeding plan. We have seen significant hypernatremia for babies who have lost significant weight of more than 12.5%, and personally I would recommend checking the sodium levels if we have rechecked the weight at the same scale and the loss is more than 12.5%. And most of the time we have seen the weight loss is more than 150. I mean, the sodium levels are more than 150, and it is due to multiple factors. One is that baby is dehydrated. Second is that mom is also not taking enough fluids, and maternal milk will have higher sodium concentration. And in total, in conjunction with each other, we'll end up having babies with very high sodium levels, and these babies may present with hyponatremic seizures. Now, we will need to discharge, I mean, we will need to establish proper feeding, and mom should be confident before we consider discharging these late preterm babies. And we recommend involving a lactation nurse who helps with initiating feeds and advises on kangaroo mother care, and also helps and teaches about the importance of breastfeeding, the latching, the techniques, everything. So preferably every hospital should have one lactation nurse. Another thing with late preterm babies may be inadequate targeted weight gains, and may need fortification or supplementation of breast milk, especially if they are significantly low birth weight. Parent education. One of the important things we need to tell them that even though baby is not admitted in an ICU postnatal ward, baby looks healthy, these babies are at risk. So they can have all these problems that I have mentioned earlier. Ask them to maintain a normal temperature even after discharging home. They need to have a proper feeding plan, preferably a written feeding plan. Otherwise, just speak to them, spend some time, involve your lactation nurse, and give a proper feeding plan, how frequently you want to feed. Ask them to count the number of wet or dirty nappies, which gives an indirect idea of how well the breastfeeding has been established. We need to advise about the bathing. Everyone wants to bath their baby straight away after taking the baby home, but that may lead on to ineffective temperature control, which may not be good for the baby. We need to ensure them, I mean, we need to tell them that baby need to have adequate weight gain, baby need to be followed up, baby's weight need to be checked regularly, monitored regularly, not at 6 weeks, but soon after discharge they need to go to nearby pediatrician and assess the weight and keep monitoring the weight for a period of maybe around 2 weeks. There are no fixed guidelines, so that we are 100% sure that feeding has been established and the baby is gaining weight appropriately. Again, different families will have different sleeping practices. Just need to tell them about sudden infant death and safe sleeping recommendations. And as I said, discharge the late preterm if the baby is medically stable, baby has adequate weight gain, feeding well for at least 48 hours, temperature maintained for at least 48 hours, age appropriate urine and stool output, and parents are agreeable and confident enough to take this baby home and able to manage the baby at home, and tell them about a proper follow-up. Thank you.